He was a morbidly obese surgeon destined for an operating table and an early death. Now he's a rebel MD who is fabulously fit and fighting to make America healthy again. This is Stay Off My Operating Table with Dr. Philip Ovadia.
Welcome back, folks. It's Stay Off My Operating Table with Dr. Philip Ovadia. We are joined today by Dr. Sandeep Palakodeti, about whom I know nearly nothing other than that he practices very close to one of my oldest and dearest friends. Patrick, if you're listening, he's not too very far from you.
Hi, Patrick.
Having said that, let me turn it over to Phil.
Yeah, awesome to be able to have another conversation with Dr. Deep. He's got a new book out, which I'm excited to talk about and hear more about. And he's another one of my colleagues out there on the forefront of medicine, trying to change the way that we practice with patients. And we look forward to talking all about that. Sandeep, why don't you start maybe just by a quick rundown of your background again, and letting people know what got you looking to break out of the traditional medical model.
Yeah, thank you for that question. I'd say, what isn't there not to like about it? I guess I grew up around healthcare for my whole life. My father was a physician, my brother's a doctor. I knew the system was broken for many years. I trained out in California, fellowship at Harvard, was on staff at the Mayo Clinic, and served as a physician and a leader in a lot of big and small institutions across the country. And I think I got a really good early sense from both a practicing clinician side and an executive side of just how very broken the healthcare system is as a clinician. I think all of us feel it as patients intuitively, but as clinicians as well, I didn't go to medical school to see patients for 7 to 12 minutes and shove medications down their throat and not talk about the things that really mattered and moved the needle in their lives, and just made to feel as if I was a widget in the machine pushing volume through, which is how the traditional fee-for-service American healthcare is set up. As a patient, very personally, I've got three grandparents who died in their 60s from heart attacks. Both my parents have diabetes and heart disease. My dad's had multiple heart attacks and stents, and I just have a bad genetic substrate. And I have 2 toddlers at home, and I look at them and realize I need to be not just limping along for the next 20 and 30 years, but thriving and in my prime performance and optimal state for 40 and 50 and 60 years, however long we can get out of this experience. And so when you pair those two things together, it becomes very painfully obvious that the current American healthcare system is not set up in a way to really promote health in the way that we would want for ourselves and our families. And so in much the same way as you did, Dr. Ovadia, I struck out to be the change I wanted to see and create a practice that seemed like it took the tenets that were important to me and put those into real operations. Things like a team that knows you deeply, from the genetic code to your culture to your blood work and imaging tests, an interdisciplinary team that surrounds you with who you need when you need it, whether that's a dietitian or a trainer or a physician or a cardiologist or a cardiothoracic surgeon or whoever it might be, and a system that is deeply preventive rather than just reactive, where we are rooting out and seeking out disease before it has become a quote unquote disease, before we get to the reactive sick care system that this country is best known for, and actually preventing disease and promoting wellness. So that's what Velocity Health is meant to be. That's our national clinical practice that we run across the country. And the ultimate asset is my playbook in distillation across hundreds and thousands and tens of thousands now of encounters with patients on what I think are some of the most important lessons from that kind of care.
Yeah, maybe talk about, because you do have a little bit of a maybe unique background that I guess we could say you were well within the belly of the beast, right? You mentioned Harvard, Mayo, right? The big institutions. And you weren't just a practicing physician there, you were in leadership, and you really got to see the system. And what's your perspective on, I think everything you just mentioned, if you say that to any patient and really to any doctor. They'll be like, yeah, sounds great, pretty obvious. So why doesn't it happen? Like, why is it so hard to get this integrated into the traditional medical system?
It's a great question. And I ask myself that a lot, despite the past 50 years of healthcare reform, on push towards value-based care, on new models of care. What's happened to our population? 70% of us are obese or overweight. 60% of us have diabetes or prediabetes, neurodegenerative conditions off the charts, children's health, terrible state. So obviously what we're doing is not working. No honest observer could say that it's working. And why is that is the question, right? It is not because of a bunch of bad actors in the healthcare system that want what's worse for patients and want to keep them sick so that we have recurring revenue. I sometimes see this stupid trope out there that doctors don't want to make you healthy because they lose their customers. Like, trust me, there's so many more people to help that we don't have access to right now. We can't help because we just don't have time. So what I'd say the biggest issue is, Phil, is institutional inertia, is the fact that 70% of physicians now are owned by a large health system or an insurer. 100,000 physicians in this country, 10% of the practicing licensed workforce in this country is affiliated or owned by Optum, which is United Health Group. One insurer owns 10% of the physician workforce in this country. When my father was a physician, every single doctor was a small business person. They went out, they hung up their shingles, they competed, they had to innovate, they had to create new processes and find ways to interact with patients. And that naturally, you are competing on who is providing the best experience to you and who is attentive to your health, who is actually going to wrap around your family and care for you. Otherwise, you go to the physician down the street. Now, the experience that most people feel is, even as clinicians, like we're just a widget in the machine. Again, we are meant to push through volume, and we are graded on relative value units. And the more relative value units we can push through, the more we get paid, the more our system gets paid. The relationship is divorced. We are all just operating in these transactional ways where, as a patient, I have an employer who pays for insurance on my behalf. That insurance contracts with a health system. That health system employs a physician, and the entire economic chain of who's delivering value to who is disrupted when it just should be me and the person who's engaging in care. And I think that's a major cause for why we see so much textbook guideline driven medicine where everything feels like it's the population general guideline statistic distilled down to every single person. That doesn't make any sense. We're all individuals. I will acknowledge it is hard to scale what I'm talking about. I think in a new age with AI and everything, we can get extremely personalized and give people a lot of access to those things. But the traditional system doesn't allow it for physicians because most of them are stuck in the machine. The last thing I'll say is, again, to the small business point, most physicians are not like us, Phil. Most physicians follow what their attendings did, and they're encouraged to keep a academic or a big system job, and you just go right into that out of residency. And so often I hear this story, and I'm hearing it more and more now, a decade, 15 years out, is people are looking back and they're like, oh man, I'm stuck. I'm 10 years in. I hate my job, but I've got kids. I've got a mortgage. I've created a lifestyle around me. I can't take a bet on doing a startup thing like you. What if it doesn't work out? I have to make a certain amount of money. Like, I can't break out of this. Yes, my employer makes me see 25 patients a day, but at least I get to control my little fiefdom and I can care for patients in the office. But everyone feels that's eroding and they're powerless to make real change in that. So we can talk about how I think we can unravel some of that, but I think that's the biggest why, in my opinion.
I'm looking at it from a patient standpoint, and I had a bunch of questions come to mind that I'm imagining the folks listening would ask you. But because of what you've done and who you are as a physician, I'd like to dig deeper into this bit that you just talked about, how the physicians are trapped, and most specifically, how they can escape. Because God knows there's a bunch of them.
Look, I think we've reached a tipping point, I believe. I think we've saturated that stat that I just said. You can't get much more than 70% fully employed and 30% independent unless you move to a fully socialized healthcare system or something. But now we're starting to swing back where every week I get a call from a senior, amazing physician leader who's, I can't do this thing in the system anymore. And they're asking and they're trying to figure out how to break out. I think most of our colleagues are not malicious people, right? They want to do what's right. And if they had the time to spend with patients and explain things and do research in the way that Phil and I do and our teams do, then I think that most doctors would practice in this way. In a lot of ways, I sometimes people ask me, like, what's the difference between what you do and primary care? In a lot of ways, it's not. I think a great primary care doc who had 90 minutes with his patients and could have an entire research team and was going deep on all the newest, latest developments, following all the latest guidelines, would practice in the way that I practice. But they're not given that opportunity, mostly because insurance pays a certain way and health systems pay them a certain way. So how do you break out of that? A few ways. I do think that there's legislation. I think there's an increasing push towards cash pay and transparency where people's dollars will be liberated for them to make consumers to make decisions on how they allocate their healthcare dollars. Even this administration has suggested we should really go big on the HSAs or flexible savings accounts that allow patients to not pay a health insurer or health system, but invest in things that matter to them, wellness and services like ours that keep them healthy and well. And the more payment mechanisms there are, the more population that starts to access those services. It is just like any supply and demand curve. I think more physicians will see, hey, there's actually a viable option. It's not so big of a bet for me to leave my big health system job and take this cool role with the startup. They're actually growing and they're doing the kind of care that I want to see. So it's going to take success stories from practices like ours, where I really believe that we can be the beacon, Phil, of showing, look, this is how you do it. Yeah, of course we have to grow and build, but if enough of us are successful, then enough of our colleagues will be inspired to do the same kinds of things. So it definitely needs the payment rails, though, to allow that to happen, Jack, I think.
Could you expand on that? And either of you expand on it.
Yeah, I think one of the main thing, right, and you can look at it from both sides, right? The patient perspective and the doctor perspective, right? But both have maybe unintentionally or unwittingly opted into this system, right? Where they're essentially, their healthcare dollars are being controlled by someone else, right? They don't have, Dr. Sandeep said, the sovereignty to say, this is where I want to spend my healthcare dollars. And that's part of, I think, both of our practices is getting patients to reframe, to think about, because I'm sure one of the main questions that Dr. Deep gets, similar to what I get, is, why don't you take my insurance? I've paid money into this insurance. I should be able to use it to get the care that I want. They acknowledge, yeah, sounds like a great model, right? I'd rather spend 90 minutes with the doctor than 10 minutes with the doctor. And I'd rather have access to all these other resources. I've already paid money in the system, and why can't I use that money? That's a big challenge. And same thing on the doctor side, right? The main way that doctors get patients these days is they get on an insurance company's plan. And the insurance company says, okay, now you can go see this doctor. And it's easy, right? They don't have to work at it. They don't have to advertise. They don't really have to find the patients. The patients come to them. But again, there's a trade-off there, because ultimately, if it's the insurance company that is paying you directly or indirectly, you're beholden to what the insurance company decides you can do or can't do as a physician. And I think,
and how much you can charge for that too, right?
Exactly.
I can't charge for a 90-minute discussion on smoking cessation or weight loss in a reasonable way that would keep the lights on in a typical practice. And Phil, I'm super curious to hear, because I've seen crazy numbers on this. If you're doing a cabbage procedure, you don't have to share, but ballpark, like people probably think you're getting paid like $50,000 for literally doing a bypass surgery on someone's heart. But what does that actually translate to after it's all said and done from insurance?
Yeah, the physician fee for performing a CABG is about $2,000.
Just
it
imagine,
has been,
just for people.
Yeah, I'll also put a further emphasis on that. It has been basically $2,000 since probably 1990, essentially.
Exactly.
Right?
So
Not
we've
insurance adjusted.
No
it has
insurance,
remained the same.
commercial insurance, CMS, Medicaid, the year-over-year physician reimbursement adjustments are basically flat, and we're basically making 1999 wages. And people have this perception that physicians make bank, but honestly, in this new system where insurance is the payer and most of us are employed, that's not the case. And can you think about what Dr. Ovadia just said? To perform a bypass surgery on your heart where you're literally, your chest is open and he's attaching arteries to your beat, $2,000. Is it worth that? Yeah, I would pay you, Phil, $2,000 to keep me alive during that situation. I'd probably pay you a lot more than that. But so on the economic side, physicians are squeezed because they don't really have any recourse for that. Phil doesn't have all that much negotiating power if he's by himself. But if he joins a big health system, if he joins Advocate or something, they'll say, look, United or Anthem or whatever, we're not going to take any of your patients unless you pay us $3,000 for this. And you're like, okay, now I've got the weight of all of these other docs around me that can at least have some negotiating power. So in that way, on the physician side, we're stuck in these, I don't know if they're golden handcuffs, we're stuck in these awkward scenarios where getting volume, getting patients, keeping the lights on is predicated on us basically taking these terms from these insurers. On the patient side, just think about your own insurance, Jack. I don't know if you use insurance or not, but for the average family in this country, $25,000 premium, $10,000 or $15,000 out of pocket deductible before any payments even happen. Then you have co-payments. Then you have 20% co-insurance if you go to the hospital. Like, you're already paying $40,000 or $50,000 out of pocket, really, if you do all the math, to be insured and to have the privilege of seeing one of those contracted health insurance doctors for 10 minutes and getting a terrible experience. Or we find that there's another way, right? You opt out of that. You get catastrophic insurance, you use crowd share type things to protect yourself against high cost claims, and you invest in wellness in the ways that matter to you, whether that's joining a practice like mine or Phil's, or it's investing in the gym and your red light therapy or whatever it is to keep you healthy and well. By far, that economic equation makes way more sense. But in a predominantly health insurance driven payment paradigm, no one wins except for shareholders of the health insurer.
That's exactly that's the conclusion I came to. Health insurance is designed to serve the health insurer.
Well, there's, I think, thankfully now, a very strong bipartisan push. I think Josh Hawley and Elizabeth Warren, who you'd never think would partner on anything, co-sponsored a bill to break up the verticalization of these big health insurers. When the health insurer owns your doctor, your pharmacy, the PBM, and your health insurance, they have every incentive to drive costs up, to reduce quality, to withhold care. And I think the stats would speak for themselves.
We have zero controversy here amongst this small group of the three of us.
Yeah, calling it like it is. Calling it like
it really is. And again, like we said, this makes sense, right? And the vast majority of doctors and patients, I think, would say, yeah, this is how it should be. But unfortunately, one of the things, is doctors gave up control of the healthcare system long ago for many different reasons. And along the lines of what you were saying, Jack, and like I've said on this program a few times before, the health system works great for everyone except the patients and the doctors. And there isn't necessarily the incentive from above to make these changes. But thankfully, there are a growing number of physicians like myself and like Dr. Deep who just weren't willing to take it anymore and trying to find some different ways. So let's shift a little bit and talk about the patient kind of perspective on this and just thinking about health, right? And how you feel that patients should be approaching their health different than, again, the way it gets presented to them within the traditional system.
Yeah, thank you. There's so many ways, but what I'd say the biggest reason for starting Velocity Health and the real philosophy around it was two things. One is I kept seeing a repeating archetype of person, one who was extremely successful and was balancing a bunch of different things in their plate on their plates, and they're CEOs and founders and busy parents, and they could plan for years-long strategies in their business and their investments. They could set KPIs and they could set long and short-term goals and how they would achieve that. And then you'd ask them that same kind of strategy for their health, and they just stare at you and say, I thought that was your job, or I don't know, I've never really thought about it. And especially in this day and age, who knows what the world will be like in 5 and 10 years? There's a viral article going around right now on AI and how 3 years from now, we're probably all vastly different professions in a lot of ways. So what do you really have control over in the next coming decade or two? We believe your health is really the only thing. You have to focus on investing in the highest ROI asset, which is your mind and your body. And the next 20 years will show amazing sort of advancements in healthcare and science. Our job is to stay as healthy and well as we can, to allow those kinds of things, to give us optionality for the future, to understand to give us the ability to choose what we want with whatever sort of happens. And that approach necessarily needs more of a first principles sort of idea. And it is not, again, going to be reactive by any means. We have to focus on the big rocks. So with every patient, we typically start with the core four, with sleep, diet, exercise, mental health, and emotional resilience. And we go very deep on all of those. We measure those things precisely. We try to really understand how much deep sleep and REM are you getting? Are you going to bed at 10 p.m. and having a 3 a.m. wake up, but you're still in bed 8 hours, you're not really feeling rested? That creates an entire cascade, an entire downstream chain of events that if we fix that thing, we could control so many others. But not many doctors really have the time or the tools or the energy or the space to focus that intently and deeply on just one of these pillars. Similarly, on exercise, for example, we get a DEXA scan and a VO2 max on all of our patients. We really want to precisely understand how much visceral fat and subcutaneous fat do you have, what is your appendicular lean mass index, and what is your cardiorespiratory reserve. And some of our patients are athletes and they want to push the limit and they want to move performance in ways that can translate on the field or on the track or whatever. But most of our patients are people in middle age who notice that they've lost a step and are staring down the barrel of the next 20 and 30 years of chronic disease and realize that they have to do something now. And so what does that mean? You have to measure those things precisely again. And so you not having the muscle or in 30 years to be able to push yourself up from a chair to stand up, or to grab your handle on the way down if you're falling, or to put a suitcase in the overhead as you're traveling in 30 years, we know that the rate of muscle decay is approximately 10% per decade. And so where are you now? Where are you starting right now? And where do we think we're going to drift down to in 30 and 40 years? Same thing with cardiorespiratory reserve. We measure VO2 max and for those that don't know, that's where you put the mask on your face. You'll see athletes too, and you run on a treadmill and it pushes you. It's measuring how many milliliters per kilogram per minute of oxygen your mitochondria are using to produce ATP. And it is one of the most predictive all-cause mortality statistics we have. The hazard ratio of all-cause mortality of death for a low VO2 versus a high VO2 max is 4. So 400% higher chance of death in the next year versus smoking or diabetes, which is a 40% higher chance of death in the following year. So it's important. And we use that in meaningful ways by saying, look, if your VO2 max is less than 25, you will have trouble walking up one flight of stairs. You will have trouble walking on flat ground for one block. So if in 30 years you want to be dancing and tossing your granddaughter around at the wedding, like you're going to need a VO2 max of 35 or something. So where are you right now? We also know that will decay around 10% per decade. Let's get you to the 45 or whatever you need to be right now so that you can do the things you want to do for the rest of your life and give yourself the optionality. So in that way, brick by brick, we start to build who is this person, again, from the genetic code through biomarkers, through imaging, through tests like VO2. We do other things like full body MRIs and gut health testing, heavy metal testing, depending on what people need, CGM, sleep studies. And all of that data helps us build a precise plan for them. We tend to focus on lifestyle first and foremost before we ever reach for any meds. We use supplements, we use peptides. We don't have any affiliation, by the way, with any manufacturer or medication or supplement or drug or anything. We don't want that to ever be part of the perception. We are just suggesting things we think the evidence would say would make you best. So that's the approach we take, Phil, is we build it block by block as we understand people and go domain by domain. And some people need a lot more work on sleep. Some people need a lot more work on something else. For the few that have it totally dialed in and they're talking to us about what are the newest peptides or let's dial in my TRT or whatever, we certainly get there with folks, but we try to emphasize those big core four before anything else.
Yeah, and you give the blueprint for all of this in your new book. It's called The Ultimate Asset, a precision medicine guide for more years at your best. And I think when a lot of people hear that, and you touched on this a little bit, right? They get the perception that that's stuff for the elite athlete, right? Who's trying to get that 1% more gain and really optimize things. But the common guy who's just struggling to get through daily life, that's like pie in the sky, doesn't apply to. So talk about what your experience has been there, taking the people who are truly starting from ground zero.
Totally. And I think that's really fair. And some people, most of our patients are not elite athletes, like full stop. That's a very small minority of who we care for. Again, our population probably fits the general population stats, about 70% obese and overweight or have some extra visceral fat, and half of them have metabolic dysfunction in some kind of way. And so, yeah, we're not starting with injectable peptides with those people. We're talking about, why don't we try a CGM for 2 weeks and let's just get a good sense, like how does sleep impact your blood sugars? How do carbs impact your blood sugars? What happens when you have a calm, stress-free day? And teaching people slow, easy, foundational lessons like that is what people come to us for. I think, just broadly speaking, on this kind of care and who it appeals to and why people should focus, I think even your comment, Phil, like the average guy who's just struggling to feel his best, that's most people that I see walking around. That's most people. And I think that's a travesty. I don't think most people should feel like they're struggling to get by. I think most people should feel great, and a few people should be on a normal curve where they don't feel so great. But that's not the perception I get of society. And I think there's a lot to unpack there. The second chapter in the book is really about this interesting philosophical underpinning of even why we're alive in middle life, right? Like, why as a human species or any species do we stay living past reproductive age? What is the point of us being 40 and 50 and 70 and 80 and 90, right? We're just a drag on society and taking resources. Why hasn't evolution selected out for that? If we look at other species, almost universally, post-reproduction, especially for men, it's you die, right? There's not that many years left. You reproduce and then you're dead. There's a few species out there, elephants, wolves, orcas, that have oftentimes a matriarch, but have a respect and a position for people or for animals in their tribe that are post-reproduction and transmit the important knowledge needed for that tribe to survive. So elephants who have a matriarch who's been around for 50 years, who knows that during a drought, there is a distant watering hole. Like they've actually studied these animals and can watch these migration patterns while all the other tribes there died off. This one lived. And you extrapolate that to human beings, and before written word and history was more documented, we transmitted our culture and our stories through our elders. It was the experience, it was the things we told them. And I would argue that in middle age and beyond, if we are not at our biological best, we're shirking our evolutionary duty to pass on the wisdom that we've gained over that many decades. That is why we're alive in our 50s and 60s and 70s. If you do the analysis on presidents, CEOs, House of Representatives, senators, mayors, there's a concentration between 55 and 65 years old, which is pretty interesting. But it's not like the 20-year-old Silicon Valley whiz kid. Like most power, most decisions are made by people in that decade. Yet it is the decade of peak biological entropy where systems start breaking down. And simultaneously, people have to hold this deep weight and responsibility and duty of leading our world forward, yet they're consumed by chronic disease. And I wonder deeply what our society would look like if we could solve this piece to a big degree on the chronic disease, on the metabolic side. How much more would we do as a culture and as a people if we gave ourselves the best shot to that? In that way, I think the philosophy of why this kind of care is important is what drives why we do this every day. And I think is going to need to be the zeitgeist that changes if we're going to make meaningful change.
I am so happy to hear you talk about post-reproduction utility. I have wondered about that for a long time. The only folks I've dared to talk about it with have been my best male friends. I think you're right. I think you have nailed it. Once we get, as humans, once we get past reproductive age, and for men, that's a lot later than it is for women, but nevertheless, that means we've got a whole lot of experience dealing with the vicissitudes of life, and we can help those who are coming along behind us. I like that answer. I don't want to get all philosophical here, but yeah, that was.
It's the calm. I think there's a passage in the book where it's like the calm guidance of a grandmother with an adolescent who's distressed, or the experienced executive in a boardroom who just brings down the temperature and maybe doesn't say the thing that the younger hot-headed one wants to say. That kind of wisdom is actually what pushes societies forward. But if those people at that age are consumed by their diabetes and their heart failure and their obesity, then we're not living up to what our actual calling is, and even from an evolutionary standpoint, in my opinion.
Wow. It's not going to be the entire possible market, but there's a segment of the market that's going to hear what you just said and go, oh, hell yeah. That's what I was waiting for. How do I fulfill my calling when I feel like crap every morning when I wake up and I can't push myself out of I have things to do in life. I have
Jack, I hear that all the time, and I get that. I sympathize with it. I'm a business person. I'm a consultant. I'm a dad, a partner. Like, it is hard to focus on your health. But what is the point? There's all sorts of phrases, right? You're either going to deal with it now or you're going to deal with it later. It's either hard now or it's hard later, right? You choose your hard, whether it's you consider discipline and focus and non-negotiable things related to your health as hard. Maybe it starts hard, but it becomes your identity over time. But it's either that or you're stuck with what I just said, which is the inevitable chronic disease that will very likely get you given our environment and what we are swimming in.
I like to dig into the business side of your your work. You know what? One of the things I don't think was made real clear is that you have a direct patient care practice, very similar to Phil's direct patient care practice. And we'll talk about the website where people can get more information. But it's very obvious that you've got a deep and broad team of people to provide the kind of healthcare that I think we all imagine we should be able to get. I'd like to know how you went from inside the system. What were some of the key steps that you, as an employee doctor, took to extract yourself that are repeatable for others who want out? And I realize you probably have unique qualifications that not everybody has. Amongst them, you communicate really well.
Thanks.
But what are some of the important things that any physician is going to be able to replicate to extricate themselves from the system and set up their own direct private care practice?
There are a few things. One, I would say you need to just have the conviction more than anything that you're done with the status quo. That needs to be this sort of burning desire. And I find it's an interesting career point for a lot of clinicians. If you're too early in your career, you're still bright-eyed, figuring everything out. If you're too late, you're resigned and you're stuck. But there's this mid-career type clinician who I think is perfectly ripe for breaking free from the system. They've seen enough, but have the energy and will to push forward and build something else. One is you need to figure out what your particular niche is and where you're going to focus and start to develop some level of expertise there. Like, I think Dr. Ovadia obviously exists in the space of expertise that people see him as the guy for certain things, right? Like we each have to define where our particular expertise is that we can flex. I think two is really understanding the infrastructure that it takes to build a practice like this is, I'm sure, very many sleepless nights and large legal bills, Phil, for you and me both on setting up these kind of practices. It's no easy feat. And my reflection on the system is that it is a feature, not a bug, in that incumbents have made the regulatory process so challenging in healthcare that it's almost impossible for the little guys like us to set up a national brand practice and be licensed in all states and be compliant in all states and have malpractice in all states. And so that's what is so daunting to most clinicians. They're like, how do I do all of that? How do I then advertise and get patients? I'm not a marketer. I've just got employed and then they just sent me patients. And I'd say the first piece on expertise, most people don't give enough credit to themselves. A lot of doctors are very smart and they know what they're talking about. They can do a particular kind of care and do it really well if they wanted to. The second and third pieces are way harder, though. And the operational stuff, I'd say, find teams and communities that help you leapfrog a little of that. For example, there's an organization we work with, Vital Physician Cooperative. It's basically a physician co-op. They crowdsource all of these resources. They'll cover your malpractice, your EMR fees, they'll find patient flow for you. They'll give you all the infrastructure you need in order to just go out there and set up a practice. They'll give you the PC MSO structure. So I think more and more savvy companies, and probably people like Phil and I who painstakingly went through this process and realized, you know what, there's like a platform play here that I can help empower a bunch of other physicians to do this. I think that will be the next wave that comes from this, like the franchise type model where any doc that wants to jump out of their current handcuff system, they don't have to figure out like, how do I buy an EMR and how do I do marketing and all that. That's set for them. They need to just be a doctor and do their thing. And then last thing I'll say, and I mix that one into that last comment, is the finding patients is the marketing piece. I think really is daunting to a lot of physicians. Like, you get fed patients by your health system or the health insurance plans that you have credentialed with. If you're just out there on your own, how are you finding people, right? Doing stuff like this, right? Phil have spent time establishing thought leadership and credibility and showing up and being in places. And that is not easy for a lot of docs. It'll take more platforms, I think, to give people the confidence to step out of the system. But most docs probably don't give themselves the credit that they can do it. And there are entire structures and teams out there willing and ready to help, but you got to have the moxie to take the plunge.
So
Phil?
It starts with believing you can.
Absolutely.
Yeah, no, I think that is probably the biggest hurdle and barrier for most doctors, right? Because we've lost that entrepreneurial, right, spirit among doctors. And all the stats that we talked about earlier, right? That doctors don't even realize this is an option anymore. The doctors that did it that way, right? You and I went and saw the independent family doctor.
Right.
We were young, and those doctors don't really exist anymore to even mentor young doctors as to, okay, this is how you do it. The system has completely flipped, and someone gets the crazy idea that they're going to do this, right? It's a big challenge because you can't just go. It's not all that easy to find someone who's done it to help you understand how to do it. And Sandeep said that's a big challenge that we're working on, but it's going to remain a challenge because there isn't a great model out there for doctors who want to do it. But yeah, I think the first step is, it's like anything else, right? The pain of remaining in your current situation has to be greater than the pain of breaking out of that situation for people to take action.
Right. I do sense a little bit of a pendulum swing on younger docs. I get increasingly more and more outreach from medical students and residents who see what I'm doing and they want to do a rotation with us. So we've set up student and resident rotations. So if any of you out there as trainees or students, we'd love to have you. We have all sorts of cool projects, but I think it's going to take that, like really showing people what is it like existing in this entirely different practice outside of the system, and for people to say, wow, I could make a living doing that. There's no reason you can't.
I'd like both of you to give me your thoughts on this question. An awful lot of the type of primary care that is practiced by the insurance employed doctors is essentially algorithmic. You have this set of symptoms, here's this set of treatments. I'm not going to pretend I'm a genius or an expert, but it seems to me like AI can do that and doesn't need to spend, I don't have to be paying a MD. I could probably have one MD to be the umbrella under which millions of different AIs practice. Crank it out. And I also firmly believe that when it comes to health care, people who actually care about their health aren't going to be happy with that. So my opinion is that direct patient care is going to be where people who want actual health care will be forced to go, simply because the alternative will be you fill out a form on an iPad and it spits out a treatment, and folks are going to hate that. Am I in the neighborhood of accurate in my prediction?
I think so. There's a few things. So standardization definitely leads to better outcomes, right? And Phil could probably talk about this way more than I can. Like we learn this with surgeons. Like people who do the same procedure over and over are really good at that procedure. People who do a procedure a few times a year tend to have more complications. So there is some wisdom to the algorithmic stuff, which is like 80% of patients are probably going to fit within the treatment algorithm for a typical hypertension escalation algorithm. But 20% is a lot of people that go off script, right? And whatever that percentage is, there's definitely going to be some percentage that algorithm doesn't apply to. And I think that's where the AI and the judgment stuff gets a little tricky. And we already have, Doctronic last month was granted permission in the state of Utah to put in medication refills on behalf of patients independent of a physician in the loop of that. And it is the first AI that's been granted prescriptive abilities. And so I very much believe, Jack, to your point, that a future practice of mine would be me as your physician, empowered by 10 sub-physician agents acting on my behalf that scour your chart and make sure that you're getting labs at the right time, that say, you mentioned that you have a budding viral illness and suggests like the easy symptomatic stuff to get in front of that I don't need to really opine on all that much once I've given the okay. But then that turns into pneumonia, and oh wait, there looks like there's a lung mass there, and oh man, is this actually cancer? And now the doctor's really got to put this stuff together and start thinking about all of this. So that's how I see it. Is I'm not afraid of the AI at all. I think it'll definitely take parts of our job, and good riddance. So many parts of our job are so terrible that are probably unsafe for patients. Even something like medication administration or refills or whatever, right? Like putting a decimal point in the wrong place can kill someone, just like self-driving cars are safer than human cars, even though it makes us all feel weird. Probably at some point the data will show that the AI doc for most stuff is safer than the average Joe PCP that you see. So I think the best docs in the world will be the ones that still very much engage with their patients, have the relational aspect, use their agents in the right way. I think there'll be a whole segment of the population that's subject to essentially AI only care because that's the only access they can get. And we'll see if there's folks who rely on just the good old humans anymore.
Yeah, I largely agree. And I look at it a lot like the airline pilots today, right? The reality is that 95% of what they do, right? They flip on the autopilot and all is good. But that 5%, when for whatever reason, the autopilot can't handle it or things don't go as expected, right? You need a good pilot there that can still land that plane safely. And that's the situation that I see in medicine. The doctor of the future will be leveraging the AI to do the routine stuff. But the problem with humans are we don't respond algorithmically. There are so many nuances about what is happening within each individual's human body that this gets to that personalized medicine approach that, yeah, the algorithm works a lot of the time, but when it doesn't, that's when you need a good doctor in there that can say, okay, this isn't going as planned, let's reevaluate. And over time, quite honestly, the AI will get better, right? Because it can see patterns that we can't within the data. But, and then, yeah, there is a human element to all of this as well that's very important. You're right, Jack. The patient isn't going to accept the information in the same way just from the AI. But if it's a doctor who's transmitting it and translating it in a lot of cases, that's what will make that the most effective care. So I think we are moving that way. I think both patients and doctors, there's going to be a lot of adjustment on how this whole system works. But ultimately, I am optimistic that it can make it better for everyone. And it's just, like I said, it's going to be the doctors that are going to survive and thrive are the ones that are going to be able to leverage this as another tool that we use rather than it's just something that's going to replace us, right? And we have to fight. An interesting analogy from the surgical world, I trained during the era largely where minimally invasive surgery was being introduced. And one of the earliest areas that this really took hold was taking out gallbladders, right? Taking out a gallbladder used to be a pretty big operation, and we'd open the patient up and you'd spend typically maybe a week in the hospital. And during my training, that largely went away. And we went to minimally invasive gallbladder surgery, and most patients are out of the hospital the day after their surgery, or even the same day these days, right? But there are enough cases where you go in to try and do it minimally invasive, and you can't. Things are too complex in there, and you got to open up and figure out how to take care of that. And what was interesting is, so I got experience doing it both ways, but a lot of the surgeons training after me they never saw an open operation because 98% of operations could be done minimally invasive. And when they then got into trouble with the minimally invasive surgery and they didn't know how to do an open gallbladder, it was a problem, right? And that's going to be the same way that we're going to be handling this AI. Is the good doctors are still going to know how to do it when the AI isn't quite appropriate, and recognize when the AI isn't quite appropriate. And doctors or the AI only approach is going to be problematic in some situations. That's what I see the landscape.
Phil, I'm super curious on this one point. I don't mean to turn the questions back on you, but as a surgeon, I saw this clip on that Elon did where he thought that in 3 years we'd have Optimus robots that were performing at or better than the best human surgeons in the world. What's your reaction to that? And do you think that'll disrupt the field even more with AI plus the robotic side of things?
Yeah, I think it will. I think 3 years, like Elon tends to be, is probably a pretty optimistic, aggressive timeline. I think it's maybe more 10 years. But again, you're going to need the surgeon overseeing the robot, because I still think there's some things there that the robot maybe won't appreciate that, okay, this isn't quite the right thing. What's interesting about the surgical question is, the technical aspects of doing surgery, I have no doubt that robots will be able to do that well. But one of the sayings that I think most surgical trainees hear throughout their training is what the difference between a good surgeon and a bad surgeon is: a good surgeon knows when not to operate. And it's not really the technical aspects of doing the surgery that usually differentiate who's good and who isn't. It's knowing when to apply that surgery and when not to apply that surgery.
Interesting.
And those are the things that I think AI maybe will have more of a struggle with, that it will be interesting to see how this all rolls out.
I agree.
Here's where I'm frustrated by both of your answers. There's a basic assumption, and maybe I read it wrong, but there's a basic assumption in your answer that the data that these things are trained on is accurate and valid. And
I think that's a fair criticism. Like
we don't need to go through the last 70 years of trust the science and then find out that it was bullshit. That's what this AI has been trained on.
Right now, I think it's mostly been trained. There's a horrific graph that shows the percentage of ChatGPT and all these LLMs that have been trained by Reddit, right? Yeah. The unhinged craziness that's on Reddit is what you come out in some of the answers too. But I think that's just the early signs, right? The real stuff will be when AI is deployed ambiently into an EMR, and it can like literally watch, how am I moving my mouse from here to here? What decisions can it impute from that? Like, how does Phil move in an operating room? I think those kinds of things, the models and even the studies, right? There's so much garbage in, garbage out stuff that comes from this. That's why I think physicians overlaying all of that will always be important. Patients going to come to me and say, we might have perfect diagnosis, and okay, you have Hodgkin's lymphoma. Here are the 5 options. Here's what the statistics say from the bot, but is it appreciating that the trade-off in quality of life for you undergoing this chemo for the next 5 years or whatever is absolutely horrendous for the outcome of 1 month of extra survival? Or what's important to you from a cultural standpoint, or what is meaningful for you to be able to spend time with your kids versus in the hospital getting your treatments, right? Like, are AI bots going to be that sort of empathetic and that level of nuance? I don't think so, but I think it will be much better than me at looking at a patient's data and saying, this person has X diagnosis with 99% certainty. I think we'll probably get to that point.
Yeah, I think the real power is in the raw data, right? Not the interpretive environment. So you're right, Jack. You train it on the medical literature, right? And we understand that there's a lot of bias in there and a lot of garbage in there. But like Sandeep said, when you say, okay, you have the raw data, right? Here's the EMR, here's the patient's wearables, here's all their lab testing and all of this. That's where it's really going to be powerful, because it's going to be able to like I said, recognize the patterns in there that we just don't have the capacity to. And that's where I have the most optimism, not in it spitting back the medical literature, because you're right, there's a lot of problems. And I think it will start that way, right? But ultimately, it will get to the raw data, right? And it will be iterating through the outcomes, and it will be able to see through the biases that are currently in the medical literature. And that's how we get to the truth. And that's what makes me optimistic about it.
I think it's a tool very much like a razor. It can be used for tremendous good or tremendous evil.
Absolutely.
And right now, there's so much money riding on maintaining the status quo that there's going to be a tremendous amount of bad outcomes prescribed by AI. And I'm the least medically qualified here to make that call, but I've watched this for decades. And can we even trust the data? We can go back to Ansel frickin' Keys, for example. Would the 22 nation study data that he did all end up in the data that AI is going to study, ingest, or is it only going to be the 7 that he published?
Yeah.
Right.
Yeah, it's a
We've
very
got
valid
70 years of bullshit about cholesterol going back to a lying researcher.
Look, I
And
think there's all of that's there and valid. And I think that there's going to be all sorts of reckoning with that kind of stuff. But
I
there's
hope
real-time
so.
data too that I hope that this AI will actually be able to prove even more that, hey, look, when we actually look across 50 years of data, regardless of this RCT, this AI has access to all of this stuff. We can see that an LDL-C of X is not correlated with Y outcomes, and more powerful and more powered than any study we could ever do. I think it could be used in that way, but very just simple, easy things like, okay, patients wearing a wearable, their heart rate variability goes down, their resting heart rate goes up. That is a signal that they're likely under sympathetic stress and probably have an impending sickness. Should they train that day or not? Probably not. Like very practical kind of advice that you can just, it doesn't really take into account medical literature. Like you have to believe that low HRV and high resting heart rate correlate with some underlying process. But if you can, I think those little things will be the first things that help us operationally understand all the data and make improvements. And then over time, I really do hope that it will open up a world of data sets that will give so much of medicine and science is reduced to what have we studied, what can we study, what are the interpretations of those studies. And that leaves a lot on the table. If you just base every single decision on that alone, you're just constrained in so many ways. So we just have to have a better way to understand reality in real time. And I do think making sense of the vast amount of data is one vector to help us do that.
This is why I'm optimistic about what you guys are doing. Because Dr. Deep, going back to how you described your current practice, you've got somebody who's part of your team whose job is research, actually doing research, finding these paradoxes and contradictions in the prescribed treatment and the actual data. And I think it's going to be a while. I think it's going to be, I don't care how fast the AI is moving. There are tens of thousands of physicians who've been trained on bad data, on bad research report, who trust bad journals that are paid for by the companies that benefit from prescribing the drugs that you guys know the story.
Absolutely.
And they don't have time to find the truth. They're on a treadmill of crank out the patients day after day just to pay their medical school loans and keep the lights on at home and make the wife happy or the husband happy, as the case may be. Don't mean to be a sexist there.
Yeah.
And breaking out gives you that chance.
I think that's exactly it. And I think that, again, that's what's going to wake up a lot of doctors, right? And force this transition that Sandeep and I were talking about. And our hope is that we and the others around us can be there to facilitate it when they're almost going to be forced into making that change, because the way that they've been doing things just isn't really going to exist anymore for them. Like you said, if you're just following the algorithm, the AI is going to be able to do that better than you are. I think that is a reckoning that's coming for a lot of our colleagues. But again, I'm optimistic about the changes that's going to push forward.
Yeah, Phil, I think, and we can wrap it up, but I think I hope what that does is start to select for people who are really relational, trusting human beings that care deeply about people, rather than memorization bots who will follow the patriarchal order of what healthcare has always been. That's the problem, is it's such a hierarchy and order that most of us don't break out of that. But I think with all these tools, when you normalize knowledge, when no human can be as smart as the computer from a pure intellectual, like factual recall standpoint, the real alpha will be your ability to relate with people, your ability to connect on a deep level, your ability to communicate complex ideas in a way that they understand that doesn't sound like AI slop. And so in that way, I hope the archetype of the practicing physician of the future will also shift to be the kind of compassionate human being that we'd all want.
Absolutely.
Said. All right. Tell people where they can get the book, where they can find out more about your practice and what you do.
Thank you again for a great conversation, Phil and Jack. You can find the book, The Ultimate Asset, on Amazon, Audible, Barnes & Nobles, all the places. VelocityHealthClinic.com. VelocityHealthClinic.com is our practice. And again, we are a concierge precision medicine clinic. We exist across the country. And we also have a podcast, The Ultimate Asset. We're on YouTube, all over X and LinkedIn and all the good stuff there. Please reach out. We're always eager for new patients and new partnerships and cool new ideas and interesting people. Really appreciate this conversation. Thank you both for having me on.
Thank you, Dr. Deep. Our guest has been Dr. Sandeep Palakodeti. I got it right the first time.
There it was.
This has been Stay Off My Operating Table with Dr. Philip Ovadia. As always, the references we talked about will be available in the show notes. We appreciate y'all joining us today. We look forward to seeing you next time.
Chances are you wouldn't be listening to this podcast if you didn't need to change your life and get healthier. So take action right now. Book a call with Dr. Ovadia's team. One small step in the right direction is all it takes to get started. Contact us at ifixhearts.com/talk. That's ifixhearts.com/talk.